Uh, Good afternoon, friends. Now we begin with the next session, next uh, instruction course. And the instruction course is Cataract Surgery Results. Are we at the finishing line? I would request Dr. Abhijit to come on the stage. We have excellent faculty with us, starting with Dr. Sandeep, Abhijit, Anaga, and Tanvi. Today, the cataract surgery results, surgical results have reached the zenith. There are so many newer equipments that have come, and so many different ways in which we are trying to achieve excellent results day after day. It's time for us to really look at them and find out if we have really taken the best use of those equipments and the procedures to reach that promised spot of getting the best possible vision that's possible. And before I start with the talk, there's one talk which was left from the previous session, and that is evaluation of a hydrophobic acrylic lens for intermediate vision. And to do that, I invite Dr. Tanvi to present the talk.
Thank you. Good afternoon, everyone. Today I'm going to talk about the intermediate visual performance with an advanced monofocal lens. This is my disclosure. In today's scenario, I think we need a lens which will give us some sort of spectacle independence for our daily routines and which are still devoid of the problems of glare, halos, or rings, or dysphotopsias that any diffractive lens may create. Monofocals have definitely proved their worth in giving a crisp distance vision, and monovision with monofocals have been successfully tried in the past. Now, Clarion is a hydrophobic acrylic IOL, which is similar, rather it has a material which is similar to the Acrosoft. It definitely has a higher water content than the previous lens, and we can see that it has a fully 6 mm usable aspheric optic and has a -0.2 anterior aspheric platform, and it helps to partially correct the average positive spherical aberration of the cornea. Now, previously a multi-center study was conducted which assessed the real-world scenario of the Clarion lens and its visual outcome and safety profile. And they found the lens gave a good distance vision and low to no significant PCO at 1 year. So we wanted to look at a different thing. We looked at the subjective and objective outcomes in patients who are bilaterally implanted with Clarion IOL while targeting them for mini monovision postoperatively. So the primary objective of our study was to see the binocular uncorrected intermediate visual acuity, which is at 66 centimeters at 3 months. And our secondary objectives were to look at the binocular. Everything was looked at binocularly. First was an uncorrected intermediate vision at 66 centimeters, both at 1 and 3 months, distance corrected intermediate vision, uncorrected distance vision at 4 meters, uncorrected near vision at 40 centimeters, and a binocular uncorrected defocus curve ranging from plus 0.5 to minus 2.5. And then we also underwent, the patients underwent a Presque score to know their spectacle dependence at 3 months. This was an investigator-initiated prospective single-center longitudinal study for a duration of 12 months. It was conducted at Lakshmi Eye Hospital and Institute, Panvel, and we enrolled 90 eyes of 45 patients. The inclusion criteria were such that the patients who had bilateral implantation with Clarion were included. They had to be more than 18 years, having an age-related, uncomplicated cataract, and pre- and post-operative corneal astigmatism should be less than 0.75 because these lenses were plain monofocal, not toric. The exclusion criteria were those who had some sort of an intraocular surgery in the past which could complicate our results, or who had any complications during surgery or even post-operatively. Any active ocular disease patients were excluded. And we looked at the post of manifest refraction too, and anybody who had a spherical equivalent of more than 0.25 in the dominant eye, which we were targeting for emmetropes, and more than 0.75 in the non-dominant eye again were excluded because we wanted to look at mini monovision. So we targeted 0 for the dominant and the 0.5 for the non-dominant. So this is just the materials and methods that we had done. I have just described them now. Now, our results showed an almost equal distribution of the demographics, male and females sort of equal. The residual spherical equivalent satisfied our inclusion criteria because the dominant eye was more or less emmetropic and the non-dominant eye had visual acuity or rather spherical equivalent less than 0.75 with the corneal astigmatism less than 0.5. Now, the mean postoperative uncorrected distance visual acuity at 1 month was 0.03, that is 20 by 20 minus 1. And the mean post-op corrected distance visual acuity at 1 month was 0.01, that is again 20 by 20. And all of this showed a similar trend at 3 months. And this has been tested previously. What hadn't been tested previously is when we looked at the uncorrected intermediate visual acuity. Almost 72% of the patients had N8 or better vision for intermediate distance at 1 month. Although when you corrected the patient for distance, the patients dropped their intermediate vision, yet a good 59% of those patients still enjoyed N8 or better intermediate vision. Similarly, at the 3rd month, 84% of patients enjoyed N8 or better intermediate vision, and after distance correction, again, still a 68% of them had N8 or better intermediate vision. Now, this trend was similar with more patients seeing better for the intermediate at 3 months, but it was not statistically significant. Now, with distance corrected, the intermediate remained N8 or better for maximum patients at 3 months, which was similarly what was seen at 1 month too. The uncorrected near visual acuity showed a good amount of patients seeing N10 and better at 1 month, and 60% of those patients had N8 or better near visual acuity binocularly at 3 months. Now, the binocular defocus curve which was done, it showed a smooth, wide profile more towards the myopic region, showing why the mini monovision is giving a good intermediate vision also while giving a good 6 by 6 for distance. The central landing zone may help us to understand why even with mini monovision, the distance still remained clear. And when we compared the defocus curve of the 1st to the 3rd month, it showed a better trend with the profile becoming smoother and wider by the 3rd month. When the patient reported independence questionnaire, which is PRISQ, that was conducted, where we saw that 96% of the patients did not need glasses for either distance or intermediate, and 60 needed glasses for near. But this is just the need. Amongst those who needed glasses, only 24% of them wore them all the time. That means they did not require glasses for near or intermediate for most others. And most of them were able to function without glasses for all distances except for 8% who needed for near all the time. And 58% said that they needed it for some or little amount of time. This need for glasses also improved from 1 month to 3 months with less need for glasses for distance, which I think the defocus curve could help us better because it got better at 3 months, so this need sort of got less. The dependence for intermediate vision also reduced from 1 to 3 months, and the trend of needing glasses was slightly better at the 3rd than the 1st. Similar trend was seen where the patients were comfortable without glasses from the 1st to 3rd month. So to conclude, bilateral implantation with Clarion IOL with targeted mini monovision is giving excellent distance as we have already seen, but a good functional intermediate vision also. There is definitely a reduced spectacle dependence for intermediate as well as near in some patients, and the visual outcome is stable over a period of 3 months. The smooth defocus curve may help if we'll end up going a little bit here and there, and definitely with the mini monovision is giving a good functional intermediate vision for practical routine. Thank you so much for your patient listening.
Good. That means there's one more addition to the EDOF
EDOF,
basket.
hopefully.
Good. Any questions, Sandeep?
No.
Yeah.
I mean, any particular reason why this particular lens gave you those results? Could it have been
So
achieved
this
with?
was my question from day one because when we kept
So
looking
it
at
would
it.
be interesting to see what is the Q value of the corneas
Exactly. So
and how
exactly.
much you're correcting.
So we are doing that. So we are
yeah.
looking at them. I feel that now to ask you, where would you look at the Q value? Like, would it be a pentacam that you would look at, or because as they say, they are partially correcting it. It's only a 0.2.
You would look at the central 5 millimeters. That's about it. Whichever.
No, but which machine would you think will give us an accurate reading
Of the cornea?
of the Q value for the cornea? Yes.
I think pentacam gives
Yeah,
a good one.
pentacam can give you.
And any shine flux give them.
Okay.
So even Cirrus gives a Q value, and we usually see that when we are advising a lens as well post LASIK.
Correct.
So
but would
then
that not be the same for any EDOFs as well? Because then that would
it
also
would.
work better in the patients who have a
Yes,
slightly
yes.
more myopic Q value.
So essentially, Clarion or IQ or those types undercorrect the spherical aberrations, and that help in the depth of focus.
Undercorrect the?
Depth of focus.
Undercorrect the Q value, they don't completely correct it. So the contrast is not as great as probably techniques because it's totally correcting it.
Yes.
Yeah.
But then in the bargain, you're getting the depth of focus to be longer.
So
Yeah,
that
so the-
study was carried out by George Baiko, who showed that a residual positive spherical aberration is actually more beneficial to patients.
Positive.
Yeah, because it gives you a depth of focus. So the Technis corrects 0.27, the IQs and the Clarion correct about 0.2. So therefore, it leaves behind something. But it has to be then customized for every patient because you'll have to look at the.
Clarion decreased it further. I think it's
No.
around 0.18 now.
0.18
0.1,
only. Even
0.18.
Acris of 0.18.
Just 0.02 here and there.
Thank you, Dr. Tanvi. And now we come to the IC that we are looking forward to. And to begin the IC, we have none other than the most prolific surgeon that I have known, a young surgeon who's really arrived on the Indian scene, Dr. Anaga. She has quite a depth of her, surgical prowess. And today she's going to speak to us on hooks, rings, segments. The question is, are we well equipped to tackle the issue and reach the imagined target of the best vision today? Dr. Anaga.
Thank you so much, sir. First of all, thank you for including me in your IC, and it's really a privilege and an honor for me. So, friends, whenever we see something like this in our OPD, the first thing that we need to remember is how are we going to manage this and what are we going to keep ready in the OR whenever we take up these patients for a surgical treatment. So, in order to know that, we all should know right from the basics that a CTR is something which is so important, whether it's an on-table sudden problem which can cause a zonular dialysis, or a use in such patients where electively you have decided to use a CTR. It's basically where you want to stabilize the capsular bag and give the patient a best visual outcome. So, which size should be used? Also, we know that it comes in different sizes, and you check the wide to wide diameter and the axial length of the eye and use these CTRs. So, the basic principle is that there is a centrifugal force and an equalization of the distribution of the forces so that you make the posterior capsule taut and stabilize the area wherever there is zonular weakening. It minimizes the fibrosis and contraction of the capsular bag also. So, what are the indications? So, first, when you have a localized zonular dehiscence of say less than 4 clock hours, whether it's due to trauma or iatrogenic, then you can use a CTR. So, important to remember is you need to have a perfect CCC. There should be no anterior capsular tears or a posterior capsular PCR also. So, intraoperatively, you first assess the extent of the subluxation, look at whether what is the number of clock hours that you have the dialysis or the zonular dehiscence. Check whether there is any vitreous prolapse. If that is there, then you need to first do an anterior vitrectomy and then only go ahead. And then even during the CCC, you can actually see whether there's an anterior capsular wrinkling or the entire phacodonesis. So these are the various. So this was a patient where when I was doing a CCC itself, you can see that there was a phacodonesis, and I knew that this patient has a mild to moderate generalized zonular weakness. There was no subluxation as such, but I went ahead and very, very carefully doing the nucleus management. But when we were doing the irrigation aspiration, we could make out that in one side, I could see the zonular bag which was getting weakened, and there was the edge that could be seen. So we stopped there, put in viscoelastic and put in the CTR, and now since we had stabilized the bag, it became much more easier, and we knew that we would not at least increase the zonular dehiscence, otherwise it could have caused greater zonular dehiscence and the entire bag could have come out. So at that point of time, you need to take that decision at when to put in the CTR, and the next step of the surgery becomes much safer, and you can go ahead and complete each step of the surgery very, very easily. So important, if you are doing a subluxated cataract, where to take the incision. So the planning has to be perfect. So ideally it should be at least 90 degrees away. Keep the section watertight. Even the capsular axis, the starting of the CCC also should be away from the area of the zonular dialysis. A very gentle hydrodissection, low flow, low vacuum settings. There is important a statement that you need to put a CTR as early as required, but as late as possible. So, for example, if you are putting it even before the phaco, putting in the CTR also is going to be very, very difficult. Managing the nucleus is going to be difficult. So many times you can put in visco underneath the CCC even before you are putting in, doing the phaco, so that you create space and then you put in the CTR. So this was a patient where there was a traumatic subluxated cataract, and we decided to go ahead and use the flax in this patient. So use of flax in subluxated cataracts gives you an added advantage, because you can not only have a perfect circular capsulotomy, but also it can you can actually position it depending on where exactly the subluxation is, how severe it is, and you can go ahead and do a perfect technique. So this was the capsulotomy, and you can see that there is a large subluxation there, almost 3 to 4 clock hours. And once you've removed the capsulotomy flap, we are using capsular hooks, and that is giving us the vertical stabilization of the capsular bag. And then it becomes easy. You go ahead, and each of those already pre-cut nuclear fragments can be easily removed. Now, before I go in for the IA, I'm putting in the CTR. Always while putting in the CTR, you have to see to it that you are stabilizing it with the second instrument, and ensure that the last part of the CTR is going in into the capsular bag. It should not slip in into the sulcus, because once that happens, then it can cause an anterior capsular tear, and you need it very difficult to go back and retrieve. Although one case had happened where then I used the bimanual technique and we retrieved the lost CTR. So once the IOL is in place, you can also remove the capsular hooks and the case is done. So this was the post-op picture. Contraindications is if there is a large anterior capsular tear or PC tear or a large Argentinian flag sign like this with a zonular dialysis, I think that becomes the most complicated way how you can manage it. So when you're using MCTR, that is the modified Sionis ring. So this was a patient, it was a 11-year-old child, and look at the astigmatism here. It's almost 11.5 diopter cylinder, grossly subluxated lens with a PSC cataract. How would you approach it? So easiest way would have been probably doing a lensectomy, vitrectomy, and then putting in either an SFIOL or an iris claw. But here you can also see the astigmatism on IOL master was just 1.77. So that 11.5 diopter astigmatism was basically lens induced, not a corneal astigmatism. So this was how we managed it. The 2 side ports and then 2 more side ports for the capsular hooks. Now in this case, the capsulotomy is extremely important, because you have to have a perfect capsular axis, and these are pediatric eyes, so they're more elastic. So very, very high risk that it could tear off in the periphery. So we put in the capsular hooks, did a very gentle hydrodissection, and it's basically no hard nucleus at all. It's basically lens aspiration with the bimanual IA. And now we are putting in the Sionis ring. So here you have the Sionis, the hook. You put in the 9-0 or a 10-0 proline, and then now we are putting in the Sionis into the capsular bag and rotating it so that the eyelet comes into the area of the maximum subluxation. This was the partial thickness triangular flap. You can also use a Hoffman's pocket, and then you put in a bent 26 gauge needle underneath the scleral flap, and then railroad the straight needle of the 9-0 proline through it, and then do it again, and you get both these sutures out, and now you can tighten it, titrate it, so that you have the knot underneath the partial thickness scleral flap, and you can see that the capsular bag has been flattened there, and on the sclera you are just tightening it. So now you have a good capsular bag which is stabilized with this, and then you can go ahead and put in the IOL. So this was the final picture. Post-operatively, vision was 6/18 because of amblyopia, but the lens was sitting well. So the advantage here is that this does not compromise the integrity of the capsular bag, but remember that the eyelet comes on top of the anterior of the capsule, not underneath it. If you were to use a CTS, you could also have used a CTS with a CTR here, and that makes it easier because CTS is very small. It has a 120-degree arc and just a 5mm radius. So you can use the CTS instead of using a modified CTR, that is the Sionis. And it can also be used, suppose that place has you have an anterior capsular tear 90 degrees away, you can still put the CTS in that area. So this was where we used a Hoffman's pocket and used the CTS with a similar technique as we did with the Sionis. And the CTS can easily help to stabilize the zonular dehiscence in that area. So again, railroading with the 90-proline and then use of the CTS. So you put the suture before putting in the CTS inside the eye, and then it works well. So to summarize the function of the CTR, so we have, it's a lot underestimated. All the subluxated cataracts you have to plan very well, keep them in your armamentarium. If you have a zonular dialysis on table, CTR is something that will bail you out to reduce the risk of intraoperative complications and post-operative capsular contractions. Thank you so much for your kind attention. Thank you.
Thank you, Anaga. Lovely talk. Now we have the next debonair of Bombay, Dr. Abhijit, a prolific surgeon. Today, everyone is talking about the robotic cataract surgery and its definite advantages over the regular surgery in spite of being a good cataract surgeon. And he, with a lot of experience with flax, he is appropriately positioned to tell us, where does flax stand today and the current status of it.
So, Anaga, wonderful talk. She's already put a point across saying that flax makes her life so easy if it's a subluxated or a dislocated lens. The science is basically the femtosecond laser, which works at a very high speed, and before you know, the entire capsulotomy is done, or it's cutting the nucleus, or it's giving us the incisions as well. Our problem with the manual phaco is, which is the most important step of phaco surgery. So every experienced surgeon would say each and every step, but the most important one is the CCC size and shape and centration. Now, especially considering the new advanced monofocal IOLs or the EDOFs or the multifocals. So you can't just say, I don't have a problem. Everybody has a problem with the CCC one day or the other. For me also, as a manual surgeon for so many years, there have always been cases which have gone slightly peripheral, or maybe I don't have the right overlap over the lens. So that's something that gives that you would get with a femtosecond: accuracy and consistency. So the consistency that a manual hand doesn't give is given by the machine. So you get the perfect CCC of the perfect size in each and every case, and you also get consistent SIA. You don't have any change in the wound construction from case to case, or a premature entry from case to case. Every patient gets the same size, the same length of the incision in the on the cornea. So I just have put this across about the docking system and the way it works in my machine. Every machine would have a different way of working, but I would prefer a machine which gives me the corneal incisions as well and corneal applications as well, because I can maximize out in complicated cases, hard nucleus cases, zonular dialysis, or even with arcus or a posterior polar. Like this is a lenticonus case which we were doing, and we found it very useful in cutting the nucleus and removing the nucleus and implanting a multifocal IOL. So your chances of implanting premium IOLs increase when you have more accuracy and more consistency in your nucleotomies. If you are doing Varion assisted, even LRIs or corneal, if you have the Varion posterior corneal curvature adjusted, arcuate keratotomies is what it offers, and that is something that you can give more predictable and more long-term results using the AK for small astigmatism. So what is the market size? When we're looking at femto, the entire world is a market, because cataract dense population is there everywhere. And this is one machine which can be used and advised for all your cataracts. And you have huge volumes to target. So our problems is, first, phacoemulsification is promoted as laser. You have a capping on insurance. And time and space required is much more. So the amount of time for counseling automatically increases out here, and the cost for each surgery also increases. So how do we tackle this? So the magic word is laser again, Even though the phacoemulsification is already known as laser, everybody wants a smartwatch. That's the way even this would work. So using the science for the commerce, you should buy a laser which has multiple uses, because that decreases the cost across. Uh, you should have the ones which are effectively used for incisions and flap, and you need to increase the volume so that the PI cost decreases, and so does the cost of the procedure. And that's how you would place your femtosecond laser surgery. So intervention marketing is something that I did actively. We coined the word bladeless cataract surgery because for all our femto cataracts, we are doing incisions, and for none of them we've ever had to use a keratome to make an incision. It's not truly a robotic surgery, but there are people who promote it as a robotic surgery. It works well for many people, but we talk about accuracy out here. So we counsel in the same area whereas the flax is kept, and it's a transparent cube. And we show the procedure on the tablets, and we tell them that, okay, this is where you're going to be operated first, and then you're going to be transferred to the other theater. And we use flax as a term for all our patients rather than a robotic surgery. We have multiple options for these kind of machines, especially the Z8 now is supposed to be a very good machine because it also gives you the option of smile or a lenticule extraction for the refractive procedure. So the business model, safety is the buzzword. Whatever and however much we may try, a manual surgery is not all the time 100% safe. So is not flax, but at least it's a step forward. Target your own patients first and then the media. The media likes testimonials, so you need to have your testimonials from the existing patients that you've operated. And to summarize, femto with cataract and corneal applications are the preferable options. The revenues generated are shared, and so are the losses when we are talking of multiple procedures. So one procedure pays for the other. And both cataract and LASIK grow together. So femto or similar is here to stay, and we need to accept it and accommodate it. Thank you.
Thank you, Abhijit. Now, I invite Dr. Sandeep, again, a surgeon with, excellent results, and has a reputation of, being a surgeon to who's who in Bombay. And he's going to talk of, today the need is the need to see without glasses. So in such a scenario, we have the monovision, we have the use of multifocals, diffractive multifocals, trifocals, and today the non-diffractive or refractive EDOFs. So he's going to tell us where are we today with regards to all these different lenses and the concepts. Sandeep.
So mono, multi, or extended depth. Is the jury still out? You can see the seats are vacant. Fortunately, they are not vacant here. Hello? You can hear me? Can I go ahead, sir? Yeah, please. Yeah. So no financial disclosures. So what are the current press myopia correcting options post cataract surgery? You can opt for monovision with monofocal and extended monofocal IOLs. You can either put in diffractive IOLs or extended depth of focus IOLs, and those are enumerated out there. And these are the optical principles that govern these three modalities that we are going to use, basically depending upon the number of foci, single or multiple, or whether you're going to have an extended depth of focus. So to begin with, monovision, traditional monovision as described for contact lenses involved correcting one eye for distance and one eye for near. And we know the problems that came with that. Then we went to modified mini monovision, where you correct one eye emetropia and the other eye you correct for 1.25 or 1.5 diopters of myopia. And micro monovision, as we're using now, where one eye is corrected for plano or a minus 0.25 and a minus 0.75 diopters or minus 1 at the most in the other eye. Now, what are the advantages of monovision is that these lenses give you excellent contrast for the chosen distances and can provide functional vision for either distance and near or distance and intermediate. There are none or minimal issues of night-type disturbances, photic phenomenon, or dysphotopsia. And let's face it, this is probably the cheapest option and the best way to go. But what are the problems with monovision? It's difficult to predict whether monovision will work. Difficult even for the most experienced surgeon to calculate and customize each case. It's difficult to identify the dominant eye in the geriatric population, especially those with significant cataract. And as we just realized, that even in the presence of a mild posterior segment pathology, this near vision can be severely compromised. And very often the patients still require to use reading glasses despite monovision. So what are the pitfalls? Obviously, patient selection is difficult. There is reduced binocular vision with increasing anisometropia. Once you go beyond 1.25, there's hardly any stereopsis left. And it's difficult to choose the right amount of anisometropia. Contact lens or spectacle monovision trial is essential first. So if you're going to plan monovision, try to give the patient some kind of a trial. But basically, this procedure involves compromises at every level. And these are some of the effects that have been seen and studied in the literature. There's reduced stereo acuity post-op. Extended reading for long periods of time becomes difficult. Patients require brighter lights. Occasionally, you need to reverse or enhance these procedures. And one little kind of a disturbing thing is that there has been disturbance of so much loss of stereopsis. It has led to postural instability at 3 meters, and it has even led to falls in some of the elderly patients. What are the current presbyopia correcting intraocular lenses that are available in the armamentarium? There are the diffractive multifocals, which are essentially bifocals, and the trifocals that came a little while ago, and now the extended depth of focus lenses. Not going to go into much details, but basically diffractive bifocals led to almost 18% loss of light and therefore loss of contrast. And of course, there were nighttime issues which were unacceptable. The modern trifocals, on the other hand, are more acceptable. And there are two types of diffraction. Either the sequential trifocal, where there are two-step heights with each one giving a little more as compared to the other. So you have one step height which gives you about 40 centimeters at near vision, and a second intermediate step height which gives around 80 centimeters. And you have the non-sequential diffraction technology, where there are actually a quadrifocal, and the third step height of 120 centimeters is directed to distance. And therefore, with the newer trifocals, the patient gets excellent distance vision, a good intermediate vision at 60 centimeters, which is more like the functional vision and not 80 centimeters, and near at 40 centimeters. It ensures spectacle freedom in almost 92% of patients, and overall patients are very satisfied and happy. So the advantages of this are basically better contrast, as 88% of the light is utilized, better intermediate and near vision in mesopic conditions, as there is a 56% increase in the area which is dedicated for these activities, and fewer glares and halos. However, there are still issues. Basically, there is a splitting of light into 3 focal points. There's a 12% loss of light. There's impacts the contrast sensitivity, especially at night. It reduces but does not completely eliminate the nighttime disturbances, and difficulty in reading, especially with people who have either a suboptimal macular health or who have some ocular surface issues and who have higher order aberrations. One thing that is very certain, that when you go in for a trifocal, you should, as far as possible, use an optical biometer. There are studies to show how that patients who have a residual refractive error following a trifocal, we just heard it in the previous session, are extremely intolerant to this phenomenon. And there has to be an assiduous management of astigmatism. Even a small amount of astigmatism in the trifocals needs to be adjusted. Otherwise, you have patients who are unhappy with these procedures. On the other hand, with extended depth of focus IOLs, there are basically the diffractive and the non-diffractive type. But for the purpose of this talk, we'll essentially stick to the non-diffractive EDOF IOLs. Basically, there is a small modification in the central anterior zone, which varies from 1 to 2.2 millimeters. Smaller the zone, higher can be the ad, as can be seen with the blue cities. But then the higher the ad, the pupil, the whole lens gets pupil dependent, and the greater the propensity for halo. So what are the advantages of EDOFs? EDOFs provide excellent distance vision. They provide excellent intermediate vision ranging from 66 centimeters in the Vivity to 1.5 meters in the Enhance. They provide good functional near vision. There is better contrast as compared to trifocals, but obviously not as good as the monofocals. And dysphotopsias and night vision issues are far less as compared to the trifocals. Can EDOFs be combined with monovision? Certainly they can. And if you want to achieve monovision with these lenses, if you use a lens like the Vivity, you can just probably do a little micro monovision, emetropia in the first eye, minus half diopter in the second eye. But if you're trying to do it with the eye Hans, you need to do about a emetropia in the first eye and minus 1.5 diopters in the second eye. So what are the key factors that one needs to make when making a choice? These things are basically dependent on the age of the patient, the personality of the patient. What does this patient do for a living? What are his visual needs as far as living is concerned? What are his visual goals as far as achieving spectacle independence is concerned? And is the patient willing to compromise? You need to look at the quality of vision that they require for these near to intermediate distances, as can be seen. So now, which lenses use in which patients? If you compare presbyopia correcting IOLs as a whole to monovision, they provide good seamless unaided vision from distance to intermediate and intermediate to near. They provide excellent distance vision binocularity without demanding interocular suppression for distance as in monovision. They're an excellent choice for patients whose profession or vocation demands good binocularity, especially stereopsis. They provide equal, if not better, intermediate vision as compared to pseudophakic monovision, and they provide far better reading vision as compared to monovision. There are some studies in the literature comparing trifocals versus mini monovision. The patients with trifocals showed a greater spectacle independence, 84% in one study as compared to only 48% in patients where monovision was attempted. Patients with trifocals obviously had a greater stereo acuity as compared to monovision, and patients with trifocals showed greater spectacle independence for near tasks, obviously again, as compared to the monovision group. So are there any patients left for monovision? Yes, there is. Pseudophakic monovision can be considered a good option in mainly those patients who have been successful monovision adapters in the past with contact lenses. They can also be considered for patients who, because of their refractive errors, have a natural kind of a monovision. It is like, difference of about a -3 diopters between the two eyes, they can certainly be considered for. And they can be considered as a good option for those patients who are unsuitable for multifocals or who may not be able to afford the higher cost of premium multifocal IOLs. To this, I will add one more thing, is that if the patient is hell-bent on getting only a monofocal lens implanted in his eye, this option of a monovision in the second eye should be considered, and they can be considered for these kind of patients. Now, ideal patients for trifocals vis-a-vis the EDOFs, those patients who are insistent on spectacle independence, especially for reading, the normal, clean, pristine eyes, healthy macula, good ocular surface with low, higher order aberrations, patients who have regular or no astigmatism, where you're very sure of your biometry, optical is preferred, where your topography is pristine, and those patients who are willing for a minor amount of nighttime issues, and these are patients who could be ideal. Also, one thing always remember, put in a trifocal for a patient who is willing for a bilateral implantation, because binocular summation and neuroadaptation is the name of the game. So obviously, every other patient may be probably, acceptable for EDOF, and especially those patients who are not suitable in trifocal, like patients with mild dry eye and ocular surface disease, mild glaucoma and macular disease such as a grade 1 ERM, patient with a unilateral cataract, patient with a monofocal IOL in the other eye, post-keratorefractive surgery, good candidates for EDOFs. Minor inaccuracies in biometry as occur with hypermature and intumescent cataracts, and patients with large mesopic pupils who are desirous of minimal spectacle dependence. What are patient factors which are not contraindications? The very demanding type A patients are a safe patient to move to the EDOF. Those who are worried about nighttime visual disturbances, those who are night drivers by profession, and those who work in dimly lit environments. When not to choose the EDOF. This is also very important. Patients who are desirous of prolonged close vision, where mono or mini monovision may not be adequate for the patient's visual needs, where there is severe loss of central vision and there is significant zonular laxity. So to summarize, monovision with monofocal IOLs can probably work only for a few selective patients. Trifocals and EDOFs provide excellent distance and intermediate vision. Trifocals, though, provide better near vision as compared to the EDOFs. On the other hand, the EDOF visual profile being better as compared to the trifocal and similar to the monofocal IOL, it can be considered for the very demanding patient and for those who are night drivers. And those desirous of spectral independence and unsuitable for trifocals can be considered for the EDOF with some adjustment for monovision. So in the race against time to find out the most effective answer for what presbyopic correction in the post-cataract age group is concerned, I don't think there is still a very clear answer, but hopefully I've been able to provide a few pearls to help you make some decisions. Thank you so much.
Thank you, Sandeep. See, now that we know that we have such excellent lenses that give you great vision, there is one spoil sport that is the cylinder. So, if you have to be really good with, then you have to know how to conquer a cylinder, and to do that, and to tell us about the present status or how far have we achieved that, I call Dr. Tanvi Haldipurkar to present a talk. She is a senior consultant at Lakshmi Eye at Panvel. Dr. Tanvi.
Until we just get connected, if we can get a poll with the hands, how many of us do use toric lenses in our practice? Does that mean the ones who have not raised don't use it?
They're too tired to put it up.
Maybe. We are very close to lunch.
We are beyond lunch. आपला टाइम 3 पर्यंत आहे. आपला टाइम 3 पर्यंत आहे. हो.
So before we waste any more time, let's go ahead. Toricity can present to us in many ways. The first step to deal with cylinders is to find if they are regular or not. And then only we'll know whether we can neutralize them completely. Now, most of the eyes shown here do not have regular astigmatism, and it is obvious to the eye. But when the cylinder may not present so frankly, it is a good idea to then view it through a different perspective. So for your analysis, which is given in most of our topographers, splits the cylinder into 4 components. So it gives you a spherical equivalent, how much of it is a decentration, how much of it is regular, and if there are any other irregularities. Over here, you can see that the astigmatism, which was quite high, almost to the tune of 4, was pretty regular. So this will do well if you correct it with a toric lens. But over here, if you look, again, there is a split of that astigmatism into 4 parts. You could see that there is a lot of irregularity or decentration of the astigmatism, and this may not do very well. You may not be able to neutralize it completely. So this, I think, is a good tool for not just you, but your patient to be explained that, see, your astigmatism, I can correct only the regular part of it. The rest may not go completely with the toric IOL. Now, once you've recognized the regular cylinder, then we have to correct it. So that's why I asked, I think we need to lower our thresholds. All of us have to correct a cylinder if it is more than 0.5 in case of a multifocal lens and more than 0.75 in a monofocal lens. It has to be looked at very systematically, and this protocol we do follow it for every patient, and it is a very comprehensive way, and let's see how we do that in each of them in detail. Getting the data is the first step for acquisition, but validating that data is the key. The axial length acquisition has become quite predictable with the newer machines. So the step where we kind of falter is getting accurate K readings. And the machines are always providing us with some clues or these red flags when the measurement is wrong. We need to just pick that up and remedy it. We have to follow certain validation criteria. They're given by Dr. Hill. Now, this is an example for lens star. Now, we need to look at the standard deviations for the K1 and K2 as well as the axis. They are in this particular report abnormal. They are more than the normal acceptable range. And when you look at the raw data, the machine has tagged one of them wrong. Now, if we omit that, there's an option to do it. The standard deviations do get better, but not entirely. And you can also see that the LED reflections in all of those Myers are not very good. And this could be dry eye, which will not give you precise readings. So looking at specific measurements or at the specific machine validation is a good idea in your practice. This website has it for most common machines. You can go online and take a printout, because at the end of the day, both these readings are just being given by your machine. But unless you really look at the raw data, you won't know how the quality of that eye was and whether you are dealing with a good eye or not. The next step to toric management is to correct the irregular astigmatism if there is. Now, this is a very simple case of pterygium. If you operate it, you are going to reduce the toric load and do very well with the toric lens. In such cases where the same eye gives such a variable result, we can then look at additional tests like an anterior segment OCT map. Over here is showing a severely thinned out epithelium, which is kind of ruling or rather telling us that it's a severely damaged eye because of dry eye, and it is going to give you inconsistent data. Or a case of an anterior basement membrane disease where the problem is just an abnormal basement membrane. So just doing a PTK smoothens it out and you no longer need a toric lens. Once you know, or rather once all of this part is taken care of, the next step is to look at the same data points in multiple ways. So a combination of a good optical biometer, an autorefractometer, and a topographer is a good basic combination to begin toric practice with. Dr. Hill had proposed that we use one instrument like the LensStar or IOL Master as the primary instrument for measuring magnitude of the cylinder, and then use the topographer as your primary instrument for the steep meridian or the axis of the cylinder. So in this eye, the LensStar is giving me the amount of astigmatism, which is then confirmed with the topography. The axis on the topographer must be within 5 degrees from the LensStar to then validate the amount of astigmatism. And then a third instrument is just used to reconfirm this data. Now, if it's too confusing, this is a much easier way. The Barrett universal formula gives us a scan where we can integrate all these values. You can put it from your different machines, and if the readings are 2, it will give you a mean of your toricity. If you're using machines which are 3 or more, it will give you a median vector, which is a much stronger reading to take. Now, until we knew about PCA and its role, our understanding was astigmatism was that we only need to measure the anterior cornea, and studies have shown there's a huge variability of PCA amongst a lot of populations, and we no longer can rely on machines which only look at the anterior cornea, because what will happen is we will overcorrect the with the rule and land up undercorrecting the against the rule. So just 2 minutes to understand the PCA better. For the same amount of anterior corneal curvature, if the posterior cornea is steeper, the total keratometry of the eye becomes less. And now we know that the posterior cornea is steeper vertically and therefore acts as a minus lens vertically and acts as a plus lens horizontally. So to simply explain, it is going to reduce our with the rule and increase our against the rule astigmatism. But the reality is slightly more complex than that, as both the anterior and the posterior cornea contribute to the corneal astigmatism, and they result in a totally different astigmatism which may have a different axis as well as magnitude. So that kind of complicates things. So the initial thought for most of the researchers was to just look at the posterior corneal astigmatism directly by different ways, or to predict it using mathematical formulae. But therefore, over time, we've understood that it's not a much better way to do. The mathematical formulas fare much better than a direct measurement of the PCA by aberrometry or any other machine. And the reason for that is the posterior cornea is a very difficult surface to quantify or to identify. And in the current scenario, we do not have any machine which can then be used as a gold standard to validate that data. So today what we can use is the Barrett toric calculator. Remember to use it from these websites because you will get the latest updates, whenever they are done. Now, the calculator gives you an option of using different sets of K for a spherical eye or power calculation and separate for a toric calculation. But this option need not be used in a routine case scenario. Then there is an option of a true K Barrett, which can be used for unusual corneas, where you can use the measured PCA option instead of the predicted PCA. So therefore, a theoretical model will not be used. You can actually input the measured PCA through your pentacam or a true K value. The other factor which we have all been talking about until now was the SIA and how it affects our planning. Now, if the same surgeon operates with the same incision size, that is 2.4 at temporal maybe, then there is a huge scatter of SIA. So if you are operating with a size more than 2.8, it would be a good idea to calculate your own SIA. Otherwise, just go with an SIA of 0.12 and then calculate. The toric outcome depends on a lot on the toric alignment during intraoperative surgery. We all have various methods to mark the eye. Initially, it is better to double check it with 2, and once you've got the hang of it, it's okay to stick with 1. The image-guided machines do give you, or rather makes the step much faster, but studies have proven they are equally good as a manual marking. Intraoperatively, what you need is a good 360-degree overlap, as Dr. Abhijit was mentioning, which is very well given by any flax surgery. And it definitely reduces the rotation of the IOL, cleaning the viscoelastic behind the lens, not overhydrating it at the end. All of these steps help to keep the IOL stable. Now, interestingly, there were 2-3 studies conducted in the last 2-3 years which show that the time that the IOL rotates after surgery is within the first 1 hour. So I think some protocols is definitely required to be changed, where you don't really jostle the patient too much, or he's not, climbing up 1 or 2 stairs immediately after surgery. Let him be in your recovery for maybe an hour or two, and then he can get shifted. And of course, as we know that rotation, if at all it occurs, it's not a good idea to re-rotate it within the first week. It is always a good idea to wait for 1 to 2 weeks and then shift it back. The Barrett RX formula, as somebody had mentioned before, is a beautiful tool because it combines 2 to 3 options and gives you what you can do best for that eye at that point. It can tell you if you need to rotate the IOL, the same IOL, or whether you need to exchange it with a different one, or if there's a small refractive spherical residual, it can even tell you about the piggyback IOL option. The final step in your toric journey is a bit tedious, but it is necessary, and it is to track your toric results. The ACRS website provides you with this double-angled plot tool to study the postoperative residual astigmatism, which will be a good guide to see if you're hitting the targets. So as you begin your toric practice, it is better to go with these corneas rather than the unpredictable ones, but that doesn't mean you can't tackle these. We have seen a lot of RK patients' videos today, and I'm sure that those patients have a very high irregular astigmatism. Now, I want to just present this study here, this case here, which had a 8-cut RK, having irregular astigmatism to the tune of 8 diopters, and we had planned for a toric lens for him. Now, what's interesting to note here is that his higher order aberrations when the pupil was 3 millimeter in an eye trace machine were very high, both internally as well as on the cornea. But when the pupil size was reduced to almost 2 millimeter, most of those aberrations had reduced significantly. So what we did is we planned a pupilloplasty with a toric lens implantation in this patient, and he was very happy with a good uncorrected visual acuity. So in the end, I want to say that our understanding of astigmatism and treating it is still evolving, with many more variables still left. And having said that, if we choose our cases well, we'll give a good visual outcome. We just need to see if we need to regularize the cornea or not. But another important thing we all have to change in our toric IOL protocol is to not look at just the cylinder on the anterior cornea, but to see what is the predicted residual astigmatism, which is what you will get when you look at a Barrett calculator. And that is what you need to correct, not just the anterior cornea. And in the end, just trust your instincts, and I'm sure you'll get a good result. Thank you so much.
Thank you, Tanvi. Thank you. That was an excellent talk. And now we move to the maestro himself. I think after almost 40 years of practice to us, he's still refining his results. And he is the one who's taught cataract surgery to most of us and most people, directly or indirectly. Suhas influences everybody. But he is still improving his results. He's still refining cataract surgery results. And that is what he's going to tell us. The journey is still on.
That's the reason you can practice even after 40 years, because cataract surgery is so very interesting. It doesn't really bore you. Every time, if you keep your mind open, there are a lot of things you can learn and improvise. In fact, I was very late to come into femto. I always believed that I can do better. But after I went in for femto, I realized that femto takes your surgical level to another level. And of course, I'm a beginner there. I have to learn it like the masters that you all are. But now, thank you so much, Sandeep, and we go to my talk. Well, some of the things that I'll be showing you here are nothing new. Probably you all are doing it, or probably you have seen them done better, but I'll just put them together. So with that, I go to my first case. See, posterior polar cataract. We have different ways of doing posterior polar cataract. I have my own way of doing, which I've been doing for a long time. What I call it is in situ 4-quadrant. Now, this is a situation where you're not doing a full hydrodissection, and you can't rotate the nucleus with a fear that the PC can rupture. So what you do is in situ 4-quadrant. That means you have to do a single trench Then you create trench on either side and weaken the girder. And once you have done it deeply enough, you can just go with the second instrument and just snap it. You don't have to use too much of strength here. So I go with the chopper and just nudge it down. It breaks there. And that way, each piece gets separated. And see, once your endonucleus is out, even if the PC is truly defective, it doesn't really hurt you much because you are left with very little things to do. And with the PC defect, you're still easily able to take care of that. So, another thing which is a very old concept but not very popularly used is the AC maintainer. I cannot tell you enough about the fantastic strength that particular concept has, and especially in cases where you truly want your AC to be formed all the time. There's nothing like an AC maintainer. Today, AC maintainer is in its new avatar, like a trocar, thing, which is even better. But for the purpose for which we use it here, the conventional AC maintainer is good enough. The reason is here it helps you keep the chamber stable, especially in a posterior polar where you truly want things to be in control. Now the real problem comes here. You are at the final stage and you still want the chamber just to remain deep enough. And sometimes what happens, you have a PC rupture there and you have an AC maintainer there, and it kind of holds it. See, now I have my irrigation from the side, whereas AC maintainer is still maintaining it. Then I go with the second, make another side port and go with the bimanual on either side. But I still continue to keep the AC maintainer there, because when you want to change sides, that is the time you want the AC to be formed. Now, this is a case where the plaque is there and there's no point in trying to scrape it any further, because the moment you try to do it, sometimes it can just give way. So what you do is you implant your lens, and after that you go with the cutter and create a central opening, because that you have to do, because or else the patient will never have that wow effect on the first post-op day. It's not possible. It's firmly stuck PC plaque, and that's a place where I do try and see if I can get, but otherwise it's the cutter that you do it, and that's it. Here what I want to show you is there's always that kind of a question. There are some surgeons who implant a lens under the visco. There are some who do it under hydro, and the reasoning behind doing it under hydro is that it takes a lot of time to get your visco out. So I thought of a technique which is a hybrid technique, because when you the problem is when you do it under visco, there's a lot of visco that goes under the lens. And the problem is it takes longer time to get visco that is under the lens out. So what I do is, at the end of the surgery, when the bag is collapsed and the anterior capsule is flat on the posterior capsule, you inject very gradually. See, if you have noticed, when you inject and the bag starts opening up and the visco starts going inside. Now you don't let those two flaps open up. Just inject a little, keeping the AC all the time shallow, but it is filled with visco. And after that, now watch what I do. What I have done before, I'll show you. So I just went with the visco. It had just filled the upper part of the chamber. I go at the irrigation from the side and fill the bag. Now the situation is the bag is filled with irrigation. On top of that is visco. And when the lens is placed, lens goes into the bag. there's hardly any visco in, and the amount of time that you need to get that visco out is also minimal. So that way you achieve your purpose. Now, this is another thing that I have started doing, because in some of the lenses, what I have realized is if the lens has a longer haptic, or depending on the material of that lens, after you have implanted and formed the chamber forms well, it's firm, but you can make out that the lens has not really gone deep into the back. The eyeball is firm, but the AC is still shallow. Now, these are the cases post-op. They'll always land up with some amount of myopia. We were talking about distension. If the fluid stays behind the lens and the lens is pushed forward, then post-op myopia. Now, for that, what I do is this. It's a routine for me. The moment I have formed up the chamber, I know that it is. Check it again. It's very simple. At the end of your irrigation, with the second instrument, push back the lens, and you can actually see the lens going back and the AC deepening. So that's the end point. Dr. Tanvi was talking about that astigmatism, the case that she showed. Now, this is that case. When you have these RK patients coming, and if that RK are multiple cut RK with badly cut, the cornea will have so many aberrations that it's always a good practice to use pinhole pupilloplasty. Now, especially in eyes where astigmatism cannot be corrected with a toric lens, the simple technique is to practice pinhole pupilloplasty with most of your cases, because it gives you amazing results. And suppose, because of that pinhole pupilloplasty, patient has complaints of lot of poor vision in the evening, in low illumination. It doesn't take you much time. You just take the patient on the YAG laser and just snip it, and the pupil opens up partly or fully. So what you have to make sure, now in this case, the pupilloplasty is done with single pass 4th row, and on both sides are up and down. And if you want to go for a true pinhole pupilloplasty, it all depends on how bad the aberrations of the cornea are. Here I've taken one suture at the top and one at the bottom. Further, you can take even on the sides, because eventually, at the end of the case, you would want the visual axis to be seen right in the center. So sometimes if I don't see it, what I'll do is I'll use a cutter to center it. So so that was, sorry. Yeah, in this case, the patient achieved 612 with a simple lens, and the cylinder came down to almost 3. Well, today, those who have an access to femtosecond, the arcuate cuts, this doesn't mean much. But for someone who's always practiced limbal relaxing incisions, or for some of you who would want to refine your cataract surgical results, especially in premium lenses, LRI is a beautiful technique to add on to your practice. It's so very simple. In my practice, I do it at the end of the surgery. The chamber is formed. You're almost complete, except for that small cylinder that is left, or a cylinder that needs to be corrected. So you have to have the guarded knife. You can use the NAPA program, where you actually go by the corneal thickness that's there, or you go by standard 600 micron depth. I prefer to go by NAPA technique, where my results become a little more accurate, because if the cornea in the periphery is 550, I would set it to 90% of 550. If it's 600, I would keep to 90% of 600. So that way, you can achieve those results. Of course, I'm sure this is nothing great, But still, if you want to refine your cataract surgical results, the time spent on peeling off those plaques at the end of the surgery make a huge difference. Now you would say uh, the center is clear. Why would you like to remove it? The reason is they are still there and there's a depth to it. When the lens sits on it, they are there between the lens and the posterior capsule. And it definitely creates some space there. I would want the lens to literally stay flat, stuck on the posterior capsule. And to do that, you must have an uneven posterior surface, posterior capsular surface. And and sometimes what happens, what you see here as slightly decentered, in actual reality, when the patient sits on the slit lamp, you will see that the plaque sometimes is right in the visual axis. So you have two choices. You are putting a premium lens. After it, maybe you can YAG it, or if possible, you can always use your surgical. Sometimes when you do this, it also gives you that kick. Oh, I could do it. Sometimes you need, because in a cataract, otherwise is a boring topic. So if you want to really make it better for your own good feeling, then these are the small techniques you can do. Here, the cystotome that I use is a little different. Regular cystotome will have a tip which is bent longer. Here you just very minimal bend, because you just need some sharp thing to lift it up. You just have to lift up that plaque and then use your forceps. This is my Rexis forceps, which is a multi-use utility forceps for me. And here I use those teeth to just pick on that just lifted plaque and just pull it and peel it, and you really can achieve excellent results. I think those were some of the cases that I thought I would share with you for refining cataract surgical results. I'm sure some of you will have a lot of good ones up your sleeves, but then they are good ones. This is how we can share our tips and make our cataract surgery results richer. With that, we come to the end, but we still have some time. So can we have a few questions? Sure.
You can ask the audience. If the audience would like to ask some questions.
Case of pupilloplasty. So in that case of pupilloplasty post-RK, I think the pre-op was 8 diopters. And after pupilloplasty, it reduced to 3 diopters. Suppose you had used a smart toric along with it, or only a smart toric, we would be able to correct the entire astigmatism. And
a smart toric of 8 or 9 diopters would correct when your astigmatism is pretty regular with non-aberrated cornea. Here the cornea is so much aberrated. See, I have seen when you have multiple cuts, your cornea also becomes multifocal in different regions. So it's always better to get the pupil down. Of course, here that was one option. But sometimes if you go off the mark and patient lands up with a additional cylinder, so I thought let's play it safe.
yeah, right.
So I noticed when Anaga was showing the case with the CTRs, she had removed a cortex in a particular quadrant, and then she was directing the CTR through that area. So that's one of a few things that that actually helps, because the CTR then goes along the equator and doesn't trap the cortex. And if you're doing that with the nucleus also, it's a good idea to do it by removing a wedge of the nucleus first and then going in that area and putting the CTR, so that your cortical wash is very easy and the CTR doesn't entangle the cortex at the equator.
Very good, very good, very good point. But Anaga, after having completed case like that, what are the situations where you just give up on the bag and take the bag out?
I think if it's a very huge dialysis, say more than 6 clock hours, and even after putting in the CTR, or if the CTR has gone into the sulcus, or when you see, there was one patient where we were trying to put in the CTR and there was a jerk and it caused an anterior capsular tear. I think in such cases, then there's no point keeping the CTR. And if the ZD has increased, then I think we probably need to just give up at that point of time.
No, I'll ask you a little differently. Now, before you put in CTR, with multiple iris hooks or capsular hooks, you are able to finish off with the nucleus management. The cortex rebole is still there. Now, in such situations, are there specific situations where even after that epinucleus is removed and you have an empty bag there, you would still give up on that bag?
If there is a PCR,
No, there's an intact bag there.
intact bag.
Would you? Any situation? Like for example, you have extensive pseudo-exfoliation. Literally, there are no zonules left, but the bag is still hanging there because you use 4 or 5 hooks, and you have done your job. Would you?
How much degree of subluxation?
Total. No, there's no subluxation.
There's no, just generalized weakness.
Generalized weakness. Practically all the zonules are lost, and the bag is hanging there with 4 or 5 hooks.
No, but if you put in a CTR and it stabilizes it, you can still put in an IOL and do a optic capture.
So
What I do, so what I like to do is play it very safe, I think, sir, I would like to put in a 3-piece lens in the sulcus and capture the optic. That way, whatever happens to the bag, your lens will always be stable for life. I think that is probably the safest option.
I would tackle it differently. I would put in a Sioni and I would do a 3-point fixation with 2 more segments. If it is that unstable, I would put in a Sioni at 1 point and I would put 2 segments for a 3-point fixation.
That's probably the way.
Yeah, but it's too complicated.
Yeah,
no, then.
and plus you don't know what's going to happen in the future.
You don't know.
It won't fall down.
It may not fall down.
I
but
have
when
I
that
have
capsule
done some
calcifies-
cases which I had done 15 years back with some zonule similar case that you're telling me. I have left them with a CTR, and 15 years now I am seeing those dislocated back complexes and I am resuturing them through the CTRs. So this is not something that you leave it on table unattended.
Okay, Abhijit. Now that femto is more popular, what would be your advice for a beginner in femto? What are the changes that he has to pay his attention to in terms of doing cataract surgery? The nucleus management or the hydrodissection or everything, because it's little different from the conventional way that you do.
So when we started off with femto, we used to do a frag and make cubes and a lot of things, but the cubes do work wonders for your effective phaco time that you're using, but you also get some cases in which some of those cubes go and hide behind the iris. So that is something you need to be very careful of in the initial stages, and over a period then we shifted to just the chops and the cylinders. So we prefer not to do cubes unless it's going to be a very hard cataract. So in the routine cases, frag is something that you should avoid. The second thing is when you're doing the rexis, usually you're going to go slightly smaller than what you would be doing normally. So if you're doing, let's say 5 millimeters, you would aim at around 4.8 on the machine, because it generally opens up a bit after you've done the femto. And for a hard cataract, you would again go slightly more wider. You would aim it at a 5 millimeter, because in a few cases what we realized post-COVID, especially when they had come, some of the hard cataracts, even when they move, the radial cuts chops sometimes go through the capsule. So that is something in which you need to be very careful, or you need to redock and do the entire thing again, or abandon the chops when you're doing the femto at that time. The other thing that I have started doing with femto is I just polish my posterior capsule. I don't polish the anterior capsule.
Yeah.
Can I add actually 2-3 things? One is indications wise, posterior polar cataract, corneal cataract, brown cataract, subluxated cataract. These are my specific indications where we would really stress to the patient that femto would play an important role. Secondly, when you're doing an IA bimanual, remember that the femto has cut the fibers vertically, so it becomes a little more difficult. So you need to, I use the polish mode to first tease out the cortex, loosen it a little bit and then aspirate it. So that makes it easier. Otherwise, you can easily catch the anterior capsular rim. And in a posterior polar cataract, the lower margin, inferior margin, instead of just a 500, we keep it around 800 to 900.
With regards to hydro, any changes?
Yeah, very, very gentle, because there is already a pneumo dissection being done. So here you need to just tap. There will be air bubbles behind the endonucleus. So just tap and very gentle hydro just to loosen it, and then those bubbles usually come in the front. Multi-quadrant and
So-
very, very small volume.
So what we
Squirts,
do
and
is
then that would
we
help.
also do a hydration through the chop. So inside out hydro dissection.
Come again?
So you go in
Oh.
the chop and give the do the hydro there as well. So it opens up a bit.
Okay.
And in guttate changes, we also use a pre-chopper instead of using the phaco to further chop the
Okay.
nucleus. So
Okay.
we go into those chops and use the pre-chopper to open it up. So that much
But
more.
actually, when you are already chopped it with the femto,
Because-
and you hold it with a sharp chopper,
But
it
where to hold it,
opens
we
up
are still using some
easily.
phaco energy. So even that is
Yeah,
saved.
that's
Tanvi,
very
sorry,
minimal.
can you will you please come and join? I'm sorry, you were all the time sitting there.
One more indication to the femto preference. In those cases who are on Urimax and other things where you're likely to expect IFIS and things can get messy later on, is better to have them chopped before. If the patient can afford it, I would put femto as an indication for patients who are on Urimax and who are likely to experience, IFIS on the table. No, the pupil doesn't come down. The trick is, as soon as you finish the femto, you put the dilating drops. Take the patient immediately. Again, you can inject a combination of epitrate and adrenaline, and it's not really a problem. In fact, I have stopped seeing those iris atrophic patches which you get with IFIS if you choose femto for these patients. I think it's a good indication. Yeah.
So what is your cutoff for the femto? I mean, if it's a small pupil, so I think small pupil and corneal opacities are the two main contraindications, you can say, or limitations. So how small would you reject a patient for femto?
I have done it in as small as I have done it in as small as a 3.5 rexes, and then I put in
Extended
a
it,
Malukin
yeah.
and then extended because I want those cuts on that hard cataract.
But
I
then those
want the
cuts will be
center-
limited to the central 3.5.
But your center is the
Central
one
is the
which is
hardest.
hard.
Yeah, so the various, it
Uh,
becomes a little messy.
you can do it. You can do it, but I'm a bit scared of that.
Yeah, little scary.
Before the infections, yeah.
I'm worried about sterility and asepsis. The moment you go inside, the femto is not actually a 100% aseptic procedure. Right. Yes. Sterile, yeah. So you mean to say you drape the patient again for the Lensex procedure, yeah, or for the femto?
I think what Abhijit says is if you can do it even for 3.5, you see, with IFAs, the pupil will not be that. If it is that small, probably we would
No,
not.
IFIS starts contracting on the table. They dilate to a respectable limit.
Yeah.
most of them.
No. If it's small, like myotic pupil or post uveitic, there's no point in doing that. But Sandeep, talking about EDOF, do you have any experience with other EDOF lenses?
Not much that I can speak in a forum, but yes, a few. IHANS have used quite a lot, yeah. But I find with IHANS, the addition that you get is only about half a diopter. It's a little unpredictable. So if patients want functional intermediate vision, they get. But if they want to have pretty good intermediate vision, no, I don't think you can get as much with that as with some of the Vivity, for example.
Anaga, now you have a lot of experience with EDOFs. So how do you kind of, counsel about EDOF? Is it just that intermediate, or do you talk in terms of reading ad that you would, need after the surgery?
Definitely. I mean, if a patient is, if you feel that the patient where glare and halos would really matter, and intermediate vision is something which is using maximum, and near vision is only say for mobile and not so much, then for him contrast sensitivity is more important, less glare and halos is important, and good intermediate vision and good distance vision is more important. And if he's ready to accept a reader, that is, I think, absolutely goes without saying that you have to communicate with them, except for lucidus and the minival and minival proxa combination, where there's fairly good near vision also.
How's your experience with
It's good.
Lucidus?
No, it is good. It is good.
Okay.
Yes, but without rings. So the chances
So,
of glare and halos
I
are
have been
less.
using a few of the Lucidus ones recently. So, just a small observation: the they have diopters, right? All the diopters, but diopters above 15, their length is around 10.4. So that the toric lenses tend to rotate. In fact, last week I have re-rotated 3 of them. So they have to be told to get the models which are 11.4, and they have to be specifically told those for all the big bags. So that's something that
No, but where you check the bag?
you can't check the bag, but you can't definitely put in a smaller lens in by default.
So
So
you
then you
can
should
look
need
at
to
the
have the
white to white,
longer
and if the
lens.
white to white is large, then probably the bag is going to be large.
But then there are 2 models in circulation, so that's what people don't know, and then they end up with a surprise with the rotation out there.
And they're being hydrophilic, they rotate more.
Yes, much more.
So you were saying something about
What's your question?
When I was not doing multifocals and EDOFs, I used to do all that. But with the Vivity, with the Lucidus, and with Panoptics, and many good trifocals in the market, I don't try to give that multifocality with the monofocals.
I think we are done. Great. Thank you so much, my esteemed faculty, for making this course very, very interactive. Thank you so much. And thank you, my dear friends who have stayed so long to be with us for this course. Thank you so much. Can we have a picture?